Hello, everyone, and welcome to our CAP webinar. Today's topic is autism spectrum disorder. I'd like to start by introducing our speakers for today. Dr. Ng Lin is a UCSF Department of Psychiatry Associate Clinical Professor and Clinical Psychologist at the UCSF Center for ASD and NDDs, meaning autism spectrum disorder and neurodevelopmental disorders. Her specialty area is in the evaluation and treatment of children with neurodiversity, specifically autism spectrum disorder and related neurodevelopmental disorders, including co-occurring psychiatric conditions related to anxiety. Her clinical and research experiences and interests are in examining and developing evidence-based treatments for neurodiverse youth to treat core symptom areas and their co-occurring mental health needs. She also has experience teaching and providing clinical supervision to provide evidence-based specialty care to neurodiverse youth to trainees in psychology, psychiatry, and other areas of medicine. Marielle Ramsay is a Spanish and English-speaking licensed clinical social worker who has extensive experience in providing therapy and other services for both Medi-Cal and commercially insured families with youth ages 0 to 18. She is an early childhood mental health specialist and has provided comprehensive services to the monolingual Spanish-speaking community. She currently serves as CAP's care coordinator, linking families to resources that may help them to better understand, access, and manage their child's mental and behavioral health concerns. And finally, Dr. Zara Szeftel is a child and adolescent psychiatrist in the Division of Mental Health and Child Development at UCSF Benioff Children's Hospital, Oakland, and the Division of Child and Adolescent Psychiatry in the UCSF Department of Psychiatry and Behavioral Sciences. She provides clinical care in the outpatient clinics at Benioff Children's Hospital, Oakland, and Zuckerberg San Francisco General Hospital and Trauma Center. And she is also a consultant here on the CAP line. And with that, I'll turn it over to our speakers.
Great, thank you so much for joining us. We'll go ahead to the next slide. Just so you're aware, this is the our disclosure information. This is our objectives for today. We would really like to help enhance pediatrician knowledge and how to make decisions to refer families for evaluation and treatment, as well as to review the resources and support for patients with ASD and their families, and then finally to end with discussion of the pharmacological treatment of psychiatric comorbidities in children and teens with ASD. All right, so I'm sure many of you are familiar with it, but I'll just go over it. So we're all on the same page again. And the purpose of this talk really is to give some more nuanced information about these two core areas that we are looking for when we're trying to come up with or figure out if a child is meeting criteria for autism spectrum disorder. So on the left side, it shows that we are looking for these deficits in social communication and social interaction, differences in social emotional reciprocity, nonverbal communication, as well as developing and maintaining and understanding relationships. And we'll go into some of those more nuances as well to help you have more informed information to help you make referral decisions. Then on the right side, we have restricted or repetitive behaviors and interests or activities. And these include several different types, like stereotyped or repetitive movements, use of objects, stereotyped language. Then we have these other areas, which is insistence on sameness behaviors, inflexible routines, and ritualized behaviors, as well as highly restricted interests and then hyper or hyposensitivities. So we're going to move forward to help you guys just have some more nuanced information to help guide referrals and these tips that we have for helping you to refer evaluations and treatment. The first part we're going to talk about is really when to consider referring a child for an evaluation. And we really want to help guide your decision making. And so I'll move to the next slide. As a pediatrician, there's so much that you're juggling in your visits, and we just want to help to streamline some things. There's three main kind of information points that a pediatrician gets when a parent comes in for a visit and there's a child, who the pediatrician or the parent might have concerns. So for parent concerns, a source of information is really to look at those screeners that you give to families about their development. And parent concern can be elicited by elevated scores on screeners, but also just from information that they relay to you during these well-child visits or any visits that children have with their pediatricians. But also they might be referring or relaying to you concerns that other people in the child's life may have shared. A family member, a friend, a teacher, or a daycare provider. And if you get any source of concern for the child's development, these are kind of red flags for you to kind of think about, okay, I think it might be time for me to refer this family for an evaluation. Another source is just the family history. So if there is a sibling in the family who is diagnosed with autism, there is a much higher likelihood that that child, one, might have ASD, but also other kinds of delays in development, as well as higher risk for ADHD. So if you hear, ooh, there is a family history, or somebody like me, a clinician, will tell a family member, hey, your eldest child was diagnosed with ASD, so now you have to tell the pediatrician for the younger siblings that this is in our family history and we really need to be monitored more closely. And so we'll go over some of that information as well. But a big important role too is just, your own concern or your own doubt that you get. And there's many sources of information you pick up on. One is directly asking parents, hey, do you have concerns about your child? And also from your direct interactions with the child. And that might be across time because you might have these multiple appointments, especially in the early years of life, or during very specific visits, or something seems, concerning with their development, or you got information from a parent. And so we want to help you to have, more knowledge of behaviors beyond what's the typical idea of what autism is, because I think those are the tricky cases that often, leaves many of us in doubt of, am I sure of what I'm seeing, or is this something that I would want to, have more information about or to refer a child? There are also specific structured tools for you to explore concern with these level 2 screeners that I'll go over more in a bit. All right, next slide. All right, so one of the tips is really just to follow the trail of parent concern. If you are hearing that there is any concern from the parent, from the sources that we talked about, from screeners like the MChat for younger kids, or the social communication questionnaire for older kids, or maybe as we talked about, the parent relays a concern they have or someone in the child's life. The reason why we want to just go ahead and follow their concerns and refer them out for evaluation is there's a lot of evidence showing that parent concern is highly correlated to a diagnosis of autism spectrum disorder. And especially during those first 2 years of life, if parents are concerned about their child, it is often more likely to be a diagnosis of autism than developmental delay or intellectual disability. And that's because those foundations for social connection, like that social communication and engagement, just comes online so early in infancy that it's those markers that parents are picking up on that are off or different. And so we want to help to disregard this notion of, oh, you're a gatekeeper, but rather maybe changing it to you're a signal detector. So if you get a signal from parents, hey, or like their screener was elevated, right? And maybe in front of you, the child looks like they're doing great, but just go ahead and to do that referral, because there is something that they're picking up on and that they're seeing over time with their child that is probably harder to pick up or more subtle to pick up on in the visits. Next slide, please. But the other thing is we want to avoid relying on just these screeners, because there's information that we're learning that with non-English speakers, racial minorities, lower income families, one, they're just less likely to be screened. And there's also growing evidence that those screeners are less accurate in girls and boys, and that it may not be sensitive to capture more nuance and subtle early signs of ASD. And that's where we want to kind of fill in the gaps so that you can have that information. But that's why you do want to use a screener, but then go ahead and asking those follow-up questions of, do you have concerns? Does anybody in your child's life, have they really concerns about your child's development? So we catch these kids who are being missed with these screeners. All right, next slide. All right, so here's some further guidance for referrals. So the research is showing that, proactive pediatrician responses are resulting in quicker autism diagnoses. There is an average delay between the first time parents relay a concern to their pediatrician and then getting a diagnosis of autism, and that's about 3 years. So even though parents may have concerns in the first 1 or 2 years of life, often the diagnoses are not made until the child's 4th year or later. And this is concerning for the children because early intervention by 2 years can make a higher impact in social communication gains. And research is showing that younger toddlers make greater gains than older toddlers. And so we really want to make sure that we're, following these signals that we're getting from these different sources of parent concern. One research even showed that research studies show that in San Diego, even though pediatricians had, positive screeners, only 40% of those positive screeners were being referred for evaluations. So that's 60% lost that didn't get referred. And so, I think knowing, hey, let's go with these concerns, let's follow it, that's going to result in these, quicker diagnoses and quicker access to treatment. But of course, as pediatricians, there may be some reason for thinking, okay, we should wait and do some monitoring. But we want to really urge to have active monitoring. So that would mean things like more frequent follow-up visits with that child, that maybe there's some suspicion, but the pediatrician are like, I'm not sure what I'm seeing. Or maybe even the parents are saying, well, I'm not concerned. And, I maybe am hesitant to get an evaluation. And so there may be different reasons why there's a strong belief to wait. But you want to probably try to set a deadline when you want to see some kind of social communication milestone being met, so that there is this active date that you're going to refer because you didn't see something coming online yet. And then you want to also, another suggestion is just to interact with the child more and to see how they are with you, so that you can get more evidence of what their behaviors and developments are like. And then you could even ask parents to track and observe how the child interacts outside of the setting, so the parent is gathering more information. But another consideration is that pediatricians and staff members can be trained to do level 2 screeners. These are things like the Autism Detection Early Childhood tool, or the screening tool for autism in toddlers and young children. That's called the STAT. You do need to be trained in these types of measures, but they're more specific in looking for ways to have structured activities and interactions with kids in the clinic, so you can come up with an informed judgment of, I have strong evidence that there is real concern of autism and I really want to refer them out. But the other line that I always just go to is just, when in doubt, refer out for an evaluation directly to psychologists specialize in ASD evaluations, or the regional center for kids under 3 years old, so that they can be able to get some of those services. All right, next slide. All right. So here are some nuanced signals to detect. And so for pediatricians to kind of think about. One is that early concerns up to 12 months old, research is showing usually they're about language delay or social concerns like joint attention. Are they looking out and pointing and kind of looking back at the parents and using that kind of joint attention? Other things are later on, 12 months and beyond, it becomes more about behavioral and motor differences. Things like lining up toys or significant emotion dysregulation that starts to kind of be the things that have become concerns for families or caregivers. Next slide. I think we all have an idea of what the common like idea of what autism looks like, right? And that might be very easy to detect during a visit. But I want to share more nuanced things that even come up for us as psychologists who are highly trained in diagnosing autism and things we consider. So the trickiest one is when children are talking, they're in a general education program, and they seem really socially interested. You know, something to keep in mind is that autism now is being diagnosed in kids with average to higher IQ, and the range is about 30 to 50%. And so, you know, it used to be very thought to be so strongly correlated with intellectual disability. And so it was very clear when somebody presented with autism. But now you're getting more kids who have average IQ, and so they're a little trickier. One of the things that we want to really look for is in the balance and quality of communication and interactions. So in both conversations and interactions, like play interactions, you really want to see this back and forth nature, that they're building on what you say and do. And most importantly, they're interested in you too. They're asking you questions about things that you're asking them questions about. Not all the time, but sometimes. The concern comes up when the interaction feels one-sided. And this comes up in different ways. One is kids who initiate a lot. They tell you things, they show you things a lot. But the problem is if you kind of take a step back and you start to put in little bits to share, they don't take you into consideration. So this might show up in play, like they're showing you toys, they're giving things to you, they're commenting, or they're telling you so much about their interests, and they're even showing you shared enjoyment. But when you start to initiate and play with them, it seems that they're very inconsistent in their responsiveness. Or what you see is a brief or limited maintenance of interactions. So again, that one-sided feeling. If you feel like you're doing all the work, because they're only answering direct questions maybe, or they don't share information about their life. You know, you have to keep asking question after question or trying to pull information from them. Or they're very brief in how they describe their experiences. You know, they might say, yeah, I went on a trip. And like they're not adding anything more. You know, those are times when you're starting to think, okay, like they're not building on what I'm doing. And I'm working so hard for them to connect with me and be a social partner. And then you're looking for what information are they sharing? Some kids share so much that you're like, oh my gosh, they're so engaged. But if you actually like listen to the content, they're telling you mostly about Minecraft or mostly about Pokemon, and there's really not a lot of variety. And that's another area where you're like, okay, there's this imbalance that they're not able to tell me about any other experiences besides these particular interests. Next slide. All right. And the next one is girls. This is so tricky. Even as psychologists who we do this every day, we are also, you know, learning about the research on this. So the overall diagnostic criteria still applies for girls with autism, but what we're finding is that they have more social interests and milder social communication impairments. There's some evidence that they're scoring at the level of typically developing boys rather than typically developing girls. So this is why you're going to get girls who are initiating, who are engaging, but the frequency, the rate is lower. They also seem to have more milder, restricted, repetitive behaviors, and that's the most consistent finding out there in the research. And their special interests are more female-related, princesses, right? You know, things that girls would like too, but they know a lot about it, and that's their sole focus. With the social interests, they do seem pretty socially interested, but they have poor skills to maintain friendships, and they're often left out by other girls. Even the girls are trying to initiate, they just don't have the skills to keep it up. And we're finding that girls often receive a later diagnosis because the social functioning challenges emerge later on in life. And so maybe for some girls, you are going to start to notice, hey, I wasn't concerned when they're younger, but now I'm getting this big concern because now they're in elementary school and I'm really worried about them. Next slide. All right. And then some nuances to think about with restricted, repetitive behaviors and interests and sensory differences. we all have them. It's transdiagnostic, repetitive types of behaviors, these kinds of things, even sensory differences. But the key to it, the difference in thinking about autism is that these behaviors and differences really limit social interactions and functioning more than other psychiatric diagnoses and more than intellectual disability. And so with sensory differences, for young children in particular, you're looking for sensory seeking behaviors, seeking out textures, visuals, peering, putting things, sniffing things, like these type of things where they're seeking things out. That is showing to be more diagnostic rather than sensory sensitivities. Sensory sensitivities are transdiagnostic, so they go across all diagnostic kinds of conditions. But again, you're looking for, okay, are these sensory differences really impairing social functioning and living more so than another kid? Then you're thinking, that might be autism. Then you have these restricted repetitive behaviors, repetitive motor behaviors like hand flapping, posturing, those things that we think are so prototypical. They show up early in life. That might be even fixation on parts of toys, or also not playing with toys as intended, but being repetitive with them. They're lining things up, or they're just carrying toys, but they're not playing with them. Then you have what are called higher order behaviors, and these show later on in development, preschool and on. And this means that they are doing behaviors like insisting on things being the same. It's almost like ritualistic or rule-bound behaviors. They create an order of how things should be done, how to get ready in the morning, how to play. And it's causing a lot of friction, because when that order isn't followed, it's really disruptive for the child and very upsetting for the child. They might also have verbal rituals of needing to say things in particular, or people in their lives responding in particular ways with how they speak. We also start to see special interests. We all have special interests, but it's more about like they have difficulty shifting to other activities or conversation topics that most children would enjoy. And then you have those kids, kind of similar to this insistence on sameness, is like they're very strict about sticking to how routines or weekly schedules were done in the past. So hopefully that helps a little bit to the nuances. Next slide. All right, now part two, I'm just going to give a little bit of information about how you can kind of guide families with treatment. And really the research shows that skills-based treatments with active practice are the most impactful for kids who are on the spectrum. Play therapy based on a psychodynamic approach is less impactful. They really benefit from structure, explicit teaching, and active practice. Another thing to keep in mind is parent involvement is key for success. Research just shows over and over those treatments that have parent coaching, where parents learn the skills and coach the kids, those are the most effective, rather than a child going into clinic on their own and then the parents are not taught any of those skills to support their child. Also, that treatment has to be personalized versus general, and then the types of treatment are going to evolve based on the age and child needs and across children. I think my last slide's coming up. Next slide. Awesome. Okay. And then the other thing is that, there's, like I said, there's a variety of different treatments because kids on the spectrum have so many different needs. Many areas are impacted, like play skills or social skills, or even co-occurring psychiatric conditions. But two therapies that I want to talk about a little more is one, behavioral therapy, which we refer to applied behavioral analysis. There's a couple of points I want to make so we can educate families better. ABA is just the science of learning how behaviors can change to be more adaptive in the environment. It's used with people and animals. It's used in various places, schools, homes, and even businesses. You guys might not know it, but behavioral principles are also, affecting you at your work. And it's across ages and needs, and it's not just for problem behaviors. And for people with neurodevelopmental delays like ASD, intellectual disability, or genetic conditions, there's two broad approaches. ABA was never meant for only kids with autism. That is an artifact of insurance dictating that. And so I really want you to know that so we can make sure that we can try to give families the right information, even though insurance might be dictating something different. but there's two broad approaches to ABA. One is discrete trial training, which has the oldest history, and the more recent, and I say more recent, but like late 70s, early 80s, is naturalistic developmental behavior interventions. And that it includes therapies like Project Impact, Pivotal Response Treatment, Early Start Denver model. They're all ABA, but they just have different approaches of thinking and considering a child's development and how they incorporate learning with a child's interests. The last part I'm going to just talk about is cognitive behavioral therapy. More and more evidence is showing CBT can be very effective for kids who are on the spectrum as well, especially to treat things like anxiety or depression or emotion regulation concerns. But it is typically best with kids who are verbal and have near average IQ, because they do still need to engage in the parts of thinking about one's thoughts and practicing actions, although it's very beneficial because it has that behavioral component too. But I'm going to stop here because I'm going to make room for my colleagues so that they can add more to this information. All right, I think Marielle is next.
Yeah, so my hope is to be able to provide some overview of the supports that are available to children and parents and caregivers, and the avenues that someone can take in order to access them. So you're all familiar with Regional Center, I imagine, which was established. There are 21 regional centers in California. It was established by the Lanterman Act. In order to qualify for the regional center, one has to have a developmental or intellectual disability. And really what's important to know is Regional Center offers the Early Start program, which is for age 0 to 3. Often the door to get into Early Start is quite wide, and it's really recommended to get as much of our young children into the Early Start program, where they can then get their services through the regional center, like speech therapy, occupational therapy, or other services directly from the regional center. However, once they turn 3, then they get their services through the school district. And there's kind of a reevaluation process to see if they have a qualifying diagnosis or symptom presentation to continue with the regional center. Once they're established, either in the Early Start program or later as a regional center client, the most important things are that they have a case manager who they know is required to be there for whatever they need. A lot of folks will hear, oh, my regional center case manager says regional center doesn't do that. For example, ABA or other services. And it's true, regional center doesn't necessarily offer those services. However, it is the responsibility of the case manager to help the family with whatever needs are coming up for them, to be a source of information, to be an advocate. And this is where the IEPP, which is the plan that's written annually, is so important, that you encourage your patients to put all of their needs into this plan so that there's accountability that the regional center is helping them. So this can be any need, anywhere from getting SSI or IHSS to help with their IEP to getting ABA. There's also something with the regional center called the self-determination program, which families can take a orientation to learn more about. And this allows a family to create a budget for additional supports that they can't get through their insurance. So this might be therapies like question therapy, music therapy that are not covered by insurance. Really, they get together, they have a team meeting, and they come up with other things outside of what's provided by insurance that they might like to help their child's development. So definitely encourage families to check out and ask their regional center case manager about the self-determination program if they're looking for more supports for their child. Next slide, please. This is just a list of some of all the things like you can get through regional center. Regional center has often their own crisis support programs, which is something regional center case managers can link them to. Depending on the regional center, there's a variety of different programs that might be available. Residential is always difficult to access via regional center or other systems of care. So it's often, you'll see regional center really try and resource the family in the home more before considering a residential placement, as they can be very difficult to access. Next slide, please. So I saw comments about this in the chat, the challenges of accessing an ASD evaluation. Under 3, so is where we see it's often easier to access because regional center really supports with this. So in the early start program for children under 3, when you have children that need an assessment for ASD, and again, this is important in the language because really when we were concerned about ASD, we want them to get specifically an assessment for ASD. But if that's something, or you have general concerns for their development, reaching the developmental milestones under 3, you refer directly to the regional center where they can get screened, assessment, and then linked to therapies, services via the regional center. And in general, we see that there's a lot of success with this program. Once they turn 3, if they're in need of an assessment, as it's possible through the regional center, and I always encourage families to start the process with the regional center of getting an assessment, so calling and requesting an assessment. And however, there's often long wait times for that assessment. So the faster route often is via the insurance, and we'll talk a little bit more about some tips to help families get a faster assessment via insurance. It's also, once they turn 3, important that they get linked to a school-based, district-based assessment. They won't diagnose autism, but they often, the school psychologists can identify that they get an IEP because they're meeting diagnostic criteria for ASD. So autistic-like learning is the qualification for the IEP, but they can often help the family really identify the need for an ASD evaluation. Next slide, please. So these tips apply to getting an ASD evaluation. They also apply to ABA, and they also apply if you want your patient to be able to get some of the other treatments that NJ was talking about, some of the other therapy. So in terms of insurance, that's where a lot of the accountability is. California law requires that insurance companies find a first appointment for patients within 15 days with a specialist. So that would be for an ASD evaluation, or 10 days for therapy or for ABA. So parents going to their insurance, calling, knowing this information, that this is, of course, there's a real impact right now in the number of providers versus the demand. However, they have this information that they're entitled by law to this first appointment. This can empower them in their drive to get an appointment. And one of the fastest ways to get an appointment with an opening is to request a case manager. So often insurances don't advertise that they offer case management, but all insurances do. And so saying, I've tried on my own, and request a case manager whose then job will be to find you a first appointment as soon as possible. And for ABA, I always recommend families, when they get assigned to an ABA provider for an assessment, to inquire about the therapy start date, because insurances will often refer to somewhere with an open assessment, but that ABA company might maintain a long wait list. So to know what if the therapy start date will be after the assessment, or if they'll be put on a wait list, so they know if they want to move forward with that ABA company or not. I encourage families to get help if they're not provided with a timely referral by their insurance. So I did make some tip sheets that we'll soon be putting on our website about this, and USPCPs have a huge role in helping communicate to that case manager that this is clinically necessary, and you advocating via the case manager can often create some accountability for the insurance to be finding an appointment as soon as possible. And then, of course, there's also the option to encourage families to make a complaint with the insurance if they're not provided with a timely referral, timely appointment, or make a complaint with the Department of Managed Healthcare if they have Medi-Cal or HMO, or the Department of Insurance, PPO. And on the tip sheet, I go into more detail about how to do that. But making these complaints will often put more pressure on the insurance companies to comply with the law regarding timely access. Next slide, please. In terms of getting help for families, these are some recommendations of some fantastic organizations that are out there that help parents with this whole process. So in terms of support with IEPs, DREDF, Matrix, Parent Helping Parents, these are great organizations. Task and EPU are in Southern California. Matrix and Parents Helping Parents is also excellent for just supporting parents with children with ASD in general. And then there's a number of other advocacy organizations. GALT is an advocacy organization that will help if a family is denied SSI or IHSS. Every regional center client has access to an attorney via the Office of Client Rights. And then there's also some excellent organizations that are specific to families, parent partners, such as the Family Resource Navigators Partner Program. I might have one more slide. That might be it. This looks up my last slide. Oh, just a reminder, some tips for helping families get the IEP to make sure that they're putting everything in writing in order to create accountability. A lot of school districts are pushing back about saying they can't do the assessment within 60 days. They are required by law to do that assessment within 60 days from the time the parent signs consent. School districts, I mentioned, will evaluate and then provide the services over age 3, and just encourage families to get the advocacy support when they're working with the school district so that they feel supported in this process and well educated. DREDF offers monthly classes in English and Spanish on Zoom. So if you go to their website, dredf.org, and anyone in California can attend these, and I hear fabulous things about it from the parents. Next slide, please. I think that's it.
All right. I'm going to use the rest of the time, try to be sensitive to what we have left, to talk a little bit about psychiatric comorbidity and medication management in patients with autism. So this diagram illustrates the diagnostic complexity in autism, showing you the core symptoms in the center there, and then the specifier categorizations that can be made by intellectual ability, language skills, and adaptive functioning in the circles below, and then the medical and psychiatric comorbidities that commonly co-occur around the outside. Clearly, many things to consider when evaluating a patient with autism, and often there is an overlap in symptoms as well as a multifactorial picture. So it does make diagnostic clarity and treatment planning challenging. From the medical perspective, we know that autism can be associated with genetic syndromes, Fragile X. People with autism are more likely to have GI issues like constipation, also more likely to have seizures. The association between autism and psychiatric or behavioral issues is well appreciated. And so I'm going to discuss the most common psychiatric comorbidities, which include ADHD, anxiety, depression, OCD, irritability, aggression. And I'll briefly touch on sleep, which is very common too. Next slide. So psychiatric comorbidity is much more common in individuals with autism than it is in the general population. Studies have shown that it's about 70% with one comorbidity and 40% with two. There's a large variability in estimated prevalence rates. Has to do with, in part, the heterogeneity of autism, but also difficulty diagnosing co-occurring disorders. It can be difficult to discern if reported symptoms are related to autism or to other common psychiatric problems. On the one hand, sensory sensitivities, for example, and social avoidance may be attributed to an anxiety disorder instead of autism. But on the other hand, autism symptoms may overshadow other mental health symptoms, for example, irritability, which is a common one, not a core symptom, but associated, and can be a symptom also of depression and anxiety. It can be attributed to the patient having frustration in communication or more severe autism. So it's really important to note that On top of that, autism presenting with psychiatric comorbidities results in more severe autism symptoms, including more repetitive behavior and just greater impairments in functioning. So a greater impairment in functioning can be a red flag that there's more going on than just autism. Next slide. So it's been reported that more than 50% of patients with autism take psychotropic medication. And this percentage increases with the increased comorbidities. Medication studies really are not plentiful in the population. Most of them are small samples, overall mixed results, and there's no medications that have evidence to treat the core symptoms of autism. And because of the difficulty diagnosing comorbid psychiatric disorders, as I described, and then the fact that the drug studies mainly looked at specific symptoms of the disorders, there's, the common approach is to really target symptoms like irritability and aggression or hyperactivity and impulsivity, rather than really being targeting the disorder, like as we do with kids without autism. And overall, starting low and going slow is our motto, due to side effects that are commonly come up. Next slide. So when do we consider psychotropic medication? First, it's really important to look at the therapies and the services that the child's receiving. So are they getting ABA? Are they getting speech therapy, occupational therapy at home or at school? Are they verbal, or are they using an alternative device to communicate? Do they have an IEP with the appropriate supports at school? Are they a regional center client? Marielle talked about all of the supports that they can get there. Does the caregiver get support through respite? In higher functioning autism, there was a mention of CBT for anxiety or depression, also parent management training for ADHD, social skills training. And then ruling out medical causes is the next important step. Presence of GI, dental issues, seizures, all of those things can cause more severe behavioral symptoms. And then after that, we start to look at the psychiatric comorbidities and evaluate and target symptoms. If the child, before considering medications, if the child does have services, it's really important to enlist the support of the treatment providers. And from there, they can do a behavior assessment where they look at triggers and reinforcers through ABA and work on modifying the behavior there. And that's mainly because our medications are really not a successful substitute for services like ABA. It would be nice if they were, but they're really most effective in combination or kind of adjunctively while doing also the behavior treatment. Next slide. So prior to DSM-5, ADHD really wasn't recognized with autism, but now we think it's the most common disorder co-occurring. 40 to 70% of kids with ASD are thought to have ADHD, and children with autism do have more prominent hyperactivity than true inattention. It's thought that the preoccupation with restricted or repetitive interests in a child with autism can contribute to distractibility. And the medication options are similar, the same ones that we would start in kids without autism, and include stimulant medications and non-stimulant medications. Next slide. So stimulants are categorized into two groups. Methylphenidates and amphetamines. Methylphenidates have a lot of data behind them. I'm probably not going to go through everything here, but just if we remember the studies without autism, the original MTA, that was a 70 to 80% response rate, and kids with autism have closer to 50%. So not as strong response there, and then more side effects. In the MTA, it was a 2% dropout, and in the studies for kids with autism, it's closer to 20%. So really there are a lot more side effects playing a role here. And irritability, emotional outbursts, and then also the appetite, insomnia, some other stuff that you always see plays the biggest role. I mentioned that hyperactivity, the treatment's more effective for hyperactivity than inattention, which can play into the symptoms of autism. And yeah, amphetamines a little bit more limited in terms of research, and they are more potent and have more side effects. Next slide. The non-stimulants, you have the alpha agonists, guanfacine and clonidine, and then atomoxetine is the other. It's a selective norepinephrine reuptake inhibitor, so different mechanism altogether. We frequently use the alpha agonists with kids with autism. Guanfacine has the most data. There are two studies, kind of a similar response rate to the stimulants, so around 50%, but a lot fewer side effects. So, and irritability and sedation being the most common ones, but they have the most data. Then there's fewer studies for clonidine, which has some success for oppositional behavior, repetitive behaviors along with the ADHD symptoms, but was not as, it wasn't effective for sleep like it was hoped in the study. So it's important to note. And then atomoxetine, Strattera is used less often, less data. It's third line after the other two I talked about. So next slide. And I think we really don't have, I had a little bit more limited time here. So I think we may not have time, honestly, for the rest of it, right?
Let's go ahead and just do like another 5 minutes or so, and reserve the last 10 for questions.
Okay. I'll try to go real quick. So internalizing disorders, anxiety, depression, OCD, they are hard to identify in children with autism due to difficulty communicating their internal state, but they are very common, especially anxiety, and easier to identify in higher functioning kids because they have usually stronger intellectual and language abilities. But in lower functioning patients, it's important to note that the disruptive behaviors can often be driven by and triggered by anxiety. So you'll kind of see it in their behavior. Anxiety's correlated with increased repetitive behaviors and sensory sensitivities, all the things we see with autism. So you'll see more of it. We treat with SSRIs more than anything else, even though they don't come along with the most data. But again, behavioral interventions are part of the picture too. Next slide. So SSRIs, there's serotonin dysregulation that's been shown in autism, and there was really hope there that that would mean that SSRIs would be super effective, and they haven't evidence-wise. The studies are, however, limited, and they're small. There's mixed results. They've targeted the core symptoms of autism, which really hasn't helped in understanding what they do for anxiety. But what we do know is that the side effects come up at lower doses, and potentially that also impacted the studies, that the doses were kind of the average starting rates, and then they ended up with more side effects and couldn't get to a therapeutic dose. Activation is the most common side effect that comes up, and looks like restlessness, irritability, agitation. Again, difficult to voice. It's more the behavior that we see, but they can still be very effective. They're highly variable, so some kids do well and others have side effects. Next slide. So this is a big one here. I think a lot of sort of, this is where we worry most about these kids when irritability, aggression, self-injury come into the picture. Not an uncommon thing in autism. And they often come along with safety concerns. And we know that aggression is more common in low functioning patients with autism, and it's associated with negative outcomes, being placed into restrictive settings, either in school or even residential settings, the use of physical interventions. And then it has an impact on caregiver stress and just day-to-day life functioning at the home. And this iceberg picture, I like how, it's able to illustrate how disruptive behaviors like hitting, biting, head banging, throwing objects, they're really what we see in these kids, while the triggers and the reinforcers, the comorbidities that drive them are almost always less obvious to us. And in approaching aggression and irritability in children with autism, it's important to first analyze the behavior. We know that behavior has a function, and especially in the context of limited communication, and asking what's going on before and after the behavior can be really helpful. And also getting, like I mentioned, the behavior therapist involved, looking at the behavior more formally in a functional analysis, and working from there on the behavior itself. And in terms of the common functions of behavior, we know avoiding demands, getting attention or access to something, and pain comes up too. So we would make sure to rule out any medical comorbidities, along the same lines as when we look at psychiatric comorbidities. And, anxiety and impulsivity. So we'll look at the common things that we see. We'll treat those with the medications that I talked about before, SSRIs, often alpha agonists, before stimulants, at least for me, due to side effect profile. And it's really important to follow these steps because as we'll review, the antipsychotic, considering the antipsychotic, which is number 3, comes along with a lot of side effects, and you're best not putting them through those without that really being thoughtful. So next slide. I'll very, very quickly, we know Risperdal is effective. We can see the differences here. They really are effective for improving irritability and aggression in autism. So I'll just go on to the next slide to talk about some side effects. So this is what limits their use. If it weren't for these side effects, we'd be using them a lot more. But second generation antipsychotics, they increase, that come along with a lot of metabolic issues. So increased appetite, weight gain, the risk of metabolic syndrome, especially with Risperdal, a little bit more of a culprit than Abilify. And Risperdal also results in a little bit more sedation. The incidence of EPS and TD aren't as much of a risk as the first generation antipsychotics, but you still have to monitor for extrapyramidal symptoms. Risperdal, we know it increases prolactin, but it's not as common that it causes gynecomastia, but it's not a side effect you want to have, so something to look out for. Akathisia with Abilify can come up. It's an uncomfortable feeling, a restlessness, but often can't be verbalized. So you see agitated behavior more often than not. And then you want to follow with monitoring lipids and A1C sort of thing. So, and then you want to reevaluate right when you start the antipsychotic. You want to reevaluate its need, and when the patient gets stable, really start to taper down. Next slide. Okay, sleep disturbances. I will not go through this whole slide, but very common in autism and really can impact behavior, both in a bi-directional way, behavior and sleep, and play a little dance together. The treatment for sleep issues in autism is behavioral because we don't have a lot of good evidence from medications. And so, doing sleep hygiene, recommending activity in the day, minimizing naps, having a nice routine. This visual bedtime schedule from Autism Treatment Network is a nice one for kids that are lower functioning, and it can really make bedtime more predictable for them. Antihistamines and alpha agonists are commonly prescribed, but really don't have as much evidence. And melatonin does not have evidence for decreasing sleep latency. All right, and I will, next slide, I'll leave it at the next slide just to show which we've kind of reviewed these things, but on the right, we don't have a lot of evidence to support use of a lot of our medications in psychiatry. We have limited options, but we try our best. All right.
Fantastic. Thank you so much for flying through that. We do have a lot of questions. Some of them actually came through the chat, and I'd like to turn it over to Marielle for some of the resource and referral questions that came through the chat.
Sure. Yeah, first five again is excellent for some of that case management support, parent partner support, for children. There was a question about, for parents, parent partners to help them when they're looking for services for their children. There was a question about early start referring, kind of limited in where early start will refer. And this is where going through insurance can be effective, because really insurance is required to provide referrals that are clinically appropriate. That is written into the California law. So they going through the insurance, there can be accountability that they need to make the referrals that are clinically appropriate. Unfortunately, you as the PCP can help put into writing what is clinically appropriate. But again, I would encourage collaboration with the regional center case manager to make sure that they're getting the referrals that they need via email and phone, requesting meetings. I often request meetings to meet with the parent and the regional center case manager. And then in terms of the question about private schools, it's true, IEPs really apply more to the public school setting unless they're being placed by the district in a private school. So again, encouraging collaboration meetings with the whole care team, where the school district is also meeting, or the school staff is also meeting with you or meeting with their providers, so that the school is really being educated about what's there being effective and what's helpful for the child.
Thank you so much for that. There's two quick medication questions that came up. One had to do with how much melatonin is used for sleep.
Because the studies aren't well controlled, I think, when you get definitely like above 5 to 10, even, you're not, there's not a lot of data there, but anything up to 10, I generally think even up to 5 really should be effective. And then in the 5 to 10 range, it's hard to say. But the studies aren't, they don't really show us a lot of dose related data on that. Above 10 does likely not effective.
Wonderful. And as we continue through the Q&A, I want to encourage people to check in either with the link that was just dropped into the chat or by scanning this QR code. But we'll continue on through some of these questions. There was a question about, are there additional resources for parents of nonverbal teens on the spectrum, especially regarding some issues around irritability and like sexual type behavior? So I'd like to throw that either to Marielle or to NG. Do you have ideas for resources?
And Jay, you want to take that one in terms of treatment, or?
How about we tag team?
Okay.
Ideally, well, maybe it does require a combination of psychiatry and behavioral interventions. And so, behavioral intervention under the basis of ABA is so effective for these, can be so effective, and it really does come down to quality of the provider and their level of training. I think that's where you get so much variability. But there are other resources, like especially in, if you're connected to regional center, there are some services to help prevent and manage some of these kinds of challenging behaviors if they can be a part of the regional center. It is unfortunate many of the behavior agencies out there are providing treatment more towards children and younger kids, but that really isn't the way behavioral therapy was meant to be used and to be helpful.
Okay, wonderful. Another question had to do with the use of hypnosis in kids with autism. Any studies or evidence for that, especially around sleep?
Thank you. I wasn't aware of that, and I will look into it more, but I don't know if, Zara, you know of anything about that.
I don't. Hypnosis really doesn't do much harm, but I don't know how much it will do. Seems like it would be calming. And I'm not aware of the formal research, so.
Great. This also kind of goes in the question of any information on the effectiveness of ketamine in ASD.
I haven't seen any. I know it's used in severe, like treatment-resistant depression, but I have not seen for autism any studies. Like, also something I will look into.
Or lithium salt, that might be another one to add to the list.
Lithium.
Yeah, lithium.
Yeah, lithium is in that category of you know, we know that lithium has data for bipolar disorder, so it would be bipolar disorder in autism, which I have seen, and it is our treatment of choice. But for other things in autism, it's you know, it doesn't have any data that I'm aware of. It's convincing.
Another question again is, I guess, looking for effective help, TMS use for ASD, this transmagnetic stimulation.
TMS I would put in the same category as ketamine. They're really the, you know, treatment-resistant approaches that are not as accessible either for depression specifically. And TMS is actually something I don't know would be well tolerated for a patient with autism. It's quite loud. I think you sit in like a helmet and it's like buzz, it's like buzzing. And I can't imagine that would be something that would be comfortable, but also something I will look into in terms of data for autism.
And I think we only have time for one more question because I think we're at the top of the hour. Finally, is older kids and adults. What kind of ASD therapy do they get? Do they get ABA, or what is it that's recommended for them? Maybe
Very
this can go to
briefly.
Angie.
Yeah, ABA also can be very helpful to adults with ASD. However, because of the way the agencies are they probably not many I know are helping to serve them, but that doesn't mean that it's not effective for them. But I think Marielle might have some additional things about regional center, being connected to regional center.
Yeah, once you are a regional center client for life. So they transition to be when they're 18 in order to be able to get continued case management. And again, this is where some of the self-determination program might be helpful. That applies because if they're denied by insurance because of age or something, then they could maybe use a self-determination program to get extra therapy supports.
Thank you. I believe we are at 1 o'clock. So thank you for everyone who showed up today. It was wonderful to have you all. Thank you to our speakers. Sorry if we couldn't get through all the questions in time, but we will do our best to get back to you if we didn't answer it, either through a typed response or live today. Hope to see you again next month in December, when our topic will be on suicide screening, assessment, and management in primary care. Thank you again.